My name is Aisha Adeyemi, and I will be the moderator for today's session. I will begin by saying that um, I will be introducing Dr. Yara Mohammed in a second. And before that, I just want to make some things clear in terms of ground rules. So please keep your mic muted during the time where Dr. Yara will be giving her um, lecture, inshallah. And also, if you would like to ask any questions, you may do so. If you want to ask the questions anonymously, we do have a link for that. If not, you can put so in the question box on the Zoom. And when Dr. Yara finishes her lecture, then we will have a Q&A conversation on the topic, inshallah. So for today, I will be introducing Dr. Yara. She will be giving her lecture for 35 minutes, if the time permits, inshallah. And as well as that, then afterwards, we will have the Q&A session, inshallah. Any questions, please put so in the chat. So just to introduce Dr. Yara Mohammed, Dr. Mohammed completed her undergraduate medical training at the University of Leicester and qualified in 2004. She completed her postgraduate specialty training in the Northwest and was appointed as a consultant at St. Mary's Hospital in 2016. Dr. Mohammed is the lead for a complex obstetric surgery service and has a special interest in abnormally invasive placentae and the management of pregnant patients with complex surgical comorbidities. She has an interest in management of benign gynecology. She is also interested in improving migrant health and supporting victims of female genital mutilations, which, as we know, is a huge problem today. Dr. Mohammed is currently the MCS lead for obstetric governance. And we are so excited to have her here today to share her knowledge with us, her expertise. And as we know, as the Emir said previously, we do know that some people have easier periods and some people have more difficult periods. And this is something that is affecting our community today. So I just would like to give a really warm welcome to Dr. Yara Mohammed to come on to do her lecture today. Assalamu alaikum, Dr. Yara.
Alaikum salam. Assalamu alaikum to everyone. Thank you so much for this invite. It's a real pleasure actually to be joining you today. Can you hear me okay? Is everything? Yeah? Okay. So I'll just share. Can everyone see the slides okay? Yeah, okay. So I thought this was a bit of a overlap or overlap for menstrual pain and what's normal for menstrual pain. So some of it is a bit brief, some of it I've tried to get into some conditions a little bit more. And I've had a look at some of the questions that were sent, so we'll see how we get on from there on. So firstly, what happens with a menstrual cycle? I find this is useful to explain just because it helps people understand what their cycle's like and what treatments there are for it. So the lining of your womb is called the endometrium, and that's there. That's the inside of the womb. It builds up during your cycle at different stages. Menstruation usually happens the day one, and then up to day 5, day 6, day 7, depending on your cycle. And then your lining of the womb will continue to build up. During that build up, there are vessels that start to form, nutrients that come to the lining of the womb. Ovulation is when you release your egg, and that happens between day 15, depending on the length of your cycle. So this is an estimate on someone who has a 28-day cycle. Then your lining of the womb becomes a little bit more sensitive in receiving for a pregnancy, if there's a pregnancy that was going to happen on that cycle. If that doesn't happen, then you have something called an ischemic phase, where the arteries start to shrink and the lining inside the womb just sheds, and then you go back to that cycle. And it's that kind of understanding of what happens at every stage helps you understand where you are and when you're getting pain, and all of the other disorders that might occur secondary to it. So, what is the history of pain? And sometimes people come to you and say, I'm in pain, and that's it. And so it's really difficult to gauge what kind of pain, and defining that pain helps us a lot understand what the cause of pain is. Your pelvic area has got so many other organs. It's got your arteries, it's got your nerve system, it's got your bowels, it's got your bladder. So being in pain and saying, I'm just in pain, and not being able to understand the pain, the history of the pain, makes it really difficult to offer a good treatment. So the first thing is how long and when did it start? So some women, like you said, would have pain throughout their cycle. So they always remember having pain. They always remember having pain with their periods. It started when they became, adolescent, and all of that through is never get better. It's really important to understand that some women will be okay, and something will start the pain, and it's important to understand what that something is. So when did it happen? When a woman always will not define when it happens properly. So does it happen in the beginning of your cycle? Does it happen when your period happens? Does it happen with ovulation? Does it happen towards the end of your cycle? Is it completely unrelated to the cycle? And that opens a little bit more of the cause of why you're in pain. What makes it better? And often an answer that everyone says nothing. And that, if you think about it, is not always going to be true, because there's something that will, if it doesn't make the pain disappear, will take the edge away. So what else happens? So are you bleeding in between your cycle? Are you bleeding after intercourse? Are you bleeding halfway through your cycle? Is your period heavy? Have you got pain when you open your bowels, when you pass urine? Have you got pain when you're intimate? And that's all important into defining why this pain is important, what's causing it. Is it related to you vomiting? Are you feeling unwell? All of that just helps us understand why there is a problem, what the cause of the problem is. So what else could it be? And sometimes, and this is partly medical, but also patient related. We just think pain has to be gynae, but actually sometimes it might be something else unrelated, but because it's the same area, it's very difficult to define. So is it worse when you eat something? Is it worse when you're stressed? Is it worse because of your muscles or your postures or after you've had a child? And all of that helps understand your history of your pain. So, what's the story behind the pain? So, the first point of contact is always going to be your GP. And that it's important to get all of that information to primary care, because they have a lot that they can do to first help before you need further intervention. So, what might the GP do? The GP might examine you. So, they need to have a feel and maybe do an internal examination. Screen for infections, and I'll go a bit more on the importance of infections. May start you on painkillers, and sometimes, we're very dismissive of painkillers. We're always dismissive that all that happened is I got painkillers, but actually, sometimes you need painkillers to help with the pain, because that helps with the symptom. It might not help with the cause, but may help with the symptoms. So start you on hormonal treatment. So a very common treatment that we offer women who have menstrual pain is the contraceptive pill, because it regulates that. And if you remember that first image I showed, regulates what hormones are given, it regulates that lining of the womb, and so might help with your pain and when your pain starts. You may arrange a scan, and that might be because of your history or because of something they found from an examination. They might refer you to a gynecologist, and again, that might be something that comes from the history and the conversation that you've had, but it doesn't take away from the treatment that they could offer you first. So the pill and the painkillers are also effective treatments to help with pain. So what causes pain? So there's a few things that cause pain. One of them is scar tissue. So women that have had previous surgery may have a lot of scar tissue because of it. And so the way your body heals means that you'll get pain around the area of the pelvis or the area of the scar, or sometimes it might be surgery that's unrelated. So, for example, if you've had an appendix removed or an appendix that burst removed and you're in pain afterwards, and that could just be scar tissue. Now, the difficulty with scar tissue is if you form a scar, then you always have a scar. So even if you had another operation, you'll still have that scar. So sometimes it is, again, managing the symptom rather than managing the cause. The second one is an infection, and there's a lot of infections that may be causing pain. A lot of women, when they come, are concerned about discharge, and discharge may or may not be a red flag for a condition. Sometimes discharge is normal, it's physiological because your cycle is changing, your mucus might be changing, but the discharge that we are concerned about related to infections might be discharge that's offensive, that is non-cyclical, that has a color, because that might indicate like an infection that's sexually transmitted or an infection that's moved around the tubes or the ovaries that might be giving you pain. So the other conditions I'm just going to go a little bit deeper to. So the first one is endometriosis. And endometriosis affects a lot of women. And what it is a condition where the lining of the womb, so over here, implants into the other areas of your pelvis. And so I'm just going to go a little bit on what's what in a female organ, because sometimes that helps explain and understand. And I'm sorry if this is a bit simple. It's not meant to offend anyone. So this is the vagina. Your neck of the womb is here, and that's where your smear comes from. And this is where we spoke about right at the beginning. That's the lining that will change according to where your cycle is. That's your tubes, and that's the ovaries. And so in some women, that patches from the lining of the womb, and we don't know why it happens, will implant on other areas. And sometimes it will implant inside the muscle of that womb, and that's called adenomyosis. And this tends to present with cyclical pain, pain with your period. In some women, they might say, well, when ovulation happens, I'm in pain, and then I start pain again, and it gets better with my period, or it just builds up completely, and I'm only pain-free from my period to ovulation. If you go back to that first image again. So what can we do for them? So endometriosis doesn't show on scan. And so a lot of women will come and say, well, you know, I've got pain, but my scan is normal. And that sometimes happens. Because it's implanted tissue, you only see things like a cyst that might be in the ovary called endometrioma. You might see some scar tissue, but you don't always see the disease by scan. There's different ways of investigating it. One investigation is an MRI scan. Your doctor might offer you that. But an MRI scan is good for picking up disease that is linked to other organs, where you've got signs or a history that may suggest it. So things like, oh, you know, you've got, when you have your period, you have problems with your bowels or bleeding through your bowels. That might be picked up by an MRI scan. So an MRI scan is a useful tool, but it doesn't pick up all of the condition. The other thing is a minor surgery, something called a laparoscopy. And a laparoscopy is a minimal surgery. So it's a keyhole surgery through the belly button. You go in, it's a general anesthetic, and you go in and see where is the endometriosis, where it's affecting, is it affecting anything outside the womb? And the treatment would depend on what the condition is and what is affected, where you are on your menstrual life. Are you completed your family, starting your family, and you're not considering a family? And all of that comes together into the decision. And then towards the end, I'll go through treatments that are not surgical, but I'll wrap it up in the end. So that's why I'm not done it now. So ovarian cysts. And many women will come really concerned about ovarian cysts and polycystic ovaries and whether that's causing pain. Now, ovarian cysts and polycystic ovaries are completely different conditions. An ovarian cyst is a fluid-filled sac around the ovary. And it's a cyst. It's like a plastic bag, if you have a plastic bag filled with water. Polycystic ovary is completely different. It's a metabolic problem, an issue with the period and the hormones rather than the cyst, and causes pain. So polycystic ovaries does not always cause pain. It causes maybe irregularities with the period, but cysts may cause pain. And so they're two different things, and sometimes they can get confused with each other. But I'll go through ovarian cysts because that might cause pain. So a lot of women will have cysts and will get really anxious that they have cysts and they'll want something doing. But the majority of cysts, especially if it's just serous fluid, actually disappear alone. They're very common within our young population. They're very common within the menstrual cycle and actually cause no symptoms. Some women might not know they're there. Some cysts, like if the cyst is caused by endometriosis or if it's caused by another not liquidy kind of fluid, might cause pain, might cause pressure. So women will say, well, actually, I feel a little bit like I'm heavy. And that also depends on the size. It might cause pain when passing urine if it's pressing on the bladder. And it's a chronic pain. It's not always pain that is acute. So the most cysts, as I said, will resolve, but a small proportion of them might rupture or twist. And that means that's an emergency because you'll get pain that doesn't get better. And if you have a cyst and you get an extreme pain, then you should always seek medical help. So the treatment, like I said, if they disappear and they're causing you no trouble, then we can leave them alone. We scan maybe a few months, and if a year nothing changes, then you don't need anything if you don't want to have it removed. If they're causing you symptoms, again, you might be offered surgery, and surgery is to remove the cyst from the ovary, but to keep the ovary behind. And the ovary is what secretes all of the eggs. And so sometimes we need to operate next to it, and sometimes we could leave it alone. Finally, fibroids. Fibroids are very common within our population. They occur in about 2/3 of the population, especially in women of Afro-Caribbean descent, but usually you see it in women who are around the age of 35 to 40. They're not usually present within the younger population, although they might be. What they are, they're non-cancerous growth. They appear inside the muscle of the womb. There's different types of them depending on where they decide to grow. And they're like a growth of muscle within the muscle. They might sometimes cause heavy periods. They might cause pressure symptoms. So some women might have problems opening their bowels or feel a bit heavy. They complain, oh, I feel a bit like I'm pregnant, things like that. The treatment depends largely on the location and then depends on the symptoms it's causing. And also, again, where you are in your menstrual life, what's the expectations, what do you want to do about them, how much of an issue it causes, and all of that. So, what treatments are there for painkillers? What treatments are there for conditions affecting gynecological women? So, like we said, painkillers. The second thing is hormonal treatment. So that depends on, again, whether you feel you've completed your family or a family is not an issue for you. So if you have been investigated and your investigations are normal, or you just need something to give you a break, then the contraceptive pill is absolutely fine. It's not only the contraceptive pill, so it's a long list of contraception. So the combined pill has both hormones in it, and you have a period with it, but it stops the ovulation temporarily, and so might help with that pain from that control point of view. Other contraception is called progesterone-based contraception, and they come as an implant. They come as a pill that you don't take a break from. They come as the rod and the coil. And the way they work is they stop the lining of the womb from building up. And if you go back to that first picture, what it does is all of that lining of the womb comes out, starts to become smaller and smaller, and then you stop having a period because you're not building it up. How that works is it stops, because it stops the lining of the womb from building up. It stops from the periods from being painful, and that's the same for all of the progesterone only ones. They're the ones that your GP or your gynecologist might say, why don't you try this for 3 months? Why don't you try the coil for 3 months? It's not the non-hormone coil, it's the hormone coil that would help. The advantage of it is that it's a quick treatment and it might work well for you. The disadvantage of it is obviously if you're trying to start a pregnancy, it's not ideal because it will act as contraception. But also with the progesterone only pill, they might make you spot outside your cycle for about 6 months to 8 months, and then it stops the period. And it stops the period not permanently, it stops the period temporarily. Now, these work or hormonal treatments work really well for women who are not starting a family or don't want to start a family, or younger girls who start with a really bad period and just need a break from the period. They work really well for women who suffer with endometriosis. If they choose to have surgery, then sometimes they reduce the coming back of the endometriosis because you're not building up that lining of the womb. The coil sometimes works well for women with also have heavy periods associated with the pain because it works inside the womb, it works locally, so it reduces the heaviness of the bleeding and the pain. It might work with fibroids that are small and not inside the cavity of the womb because it stops that heaviness of the period, but it doesn't take away the fibroid, it just helps with the symptom. Other hormonal treatment that you might be offered is an injection, and usually that's for women that have either had surgery for endometriosis or are slightly older and just don't want to have surgery, where you can have an injection or a tablet that essentially stops the ovaries from working, so it gives you menopause, and so stops feeding the fibroid, and that might help stop the period, but also shrink the fibroid slightly or help with the endometriosis not building up again. So all of these are things that you can have to help manipulate your own hormones to help with the symptoms of either heavy period or a painful period or a bit of both. They help from that point of view. If you choose like a hormone treatment that gives you menopause, then sometimes women don't like the side effects of it because it gives you side effects like hot flushes, feeling unwell, and you can't really use it for a very long time, but you can always have hormone replacement with it. So it's something that can work on helping to control the symptoms by not having a lot of surgery. So it's a temporary measure. Someone also put in the question about other things that are available for fibroids that are not surgery. The other option for fibroids, and only works for fibroids, is destroying the blood supply to the womb. And that's done by radiology. It's not done by gynecology. And what that does essentially is help shrink the fibroid because it doesn't get the blood supply. and that's the final option that you can have for fibroids, but it's not for cysts and it's not for endometriosis. But with that you have to have completed your family. So it's better for women who have completed their family but don't want to have surgery. That's the last option for them. The final option is surgery. So a lot of these conditions we can do through keyhole surgery, depending on your history, what operations you've had, and where the conditions are. So removing a small cyst can be done by keyhole surgery. Removing endometriosis, depending on how severe it is, can be done by keyhole surgery. And it's a fairly safe operation. It's a minor operation, but like anything, any surgery has its risks. But it's to remove the condition, it's to remove the disease, is to see whether removing the endometriosis makes your symptoms better, removing the cyst makes your symptoms better. Sometimes you can take fibroids out, and you can take fibroids out depending on their size and their location, either by keyhole surgery or by an open procedure or by a minor operation that goes inside the womb. And all of that might help with the symptoms of taking it out. But they might come back in the future, but that might help temporarily with the symptoms. The final option is offering to remove the womb, which is a major operation, but also an operation that helps with pain and heaviness of the period if the pain is associated with that. And that's it's a safe operation, but again, it's got its risks associated with it. So there's a wide range of options that people have, depending on also what you want, what you feel you need, where you are in your life, and sometimes what you wanted 20 years ago is very different from what you want today. So finally, what can you do to help yourself? And I think we also always forget a healthy person always affects the healthiness in them. So keep a diary, see what triggers it. A lot of younger women now will have their own apps and will use their apps to track when they have moods and when they're heaviness, and that's really useful actually. It's a benefit of this modern society. Sometimes changing your diet, and I get a lot of women that come and say, "Oh, if is my fibroid because of meat, or is this?" And it isn't. But sometimes having a healthier diet not only improves your uh, own kind of health, and your bowels may be a bit irritating as well, but also will help you become healthier if you needed surgery. Exercise is really useful. Exercise is really useful, especially if your pain is causing you stress or is caused by stress. So we sometimes forget that we are humans that are affected by other life events. And so sometimes women will have problems within their marriage or within their family or within something traumatic that's happened with them, and suddenly they feel pain. So helping yourself get better and healthier sometimes helps manage these pains and shouldn't be dismissed. It should be things that we encourage. Sleeping better and helping yourself sleep better all helps you. So all of that come together should help kind of, if not help with the mental aspect of having pains or heaviness, can help you be healthier if you needed surgery or if you needed to go on the tablet or if you needed something. And so I'm a big advocate on trying to be as healthy as possible for managing your treatments. So that is me. That's my final slide. I know I've whistled through things, so I'm happy to go through things if people want me to go through a certain element of that presentation. So I'll go back to Aisha, I think.
Assalamu alaikum. Jazakallah khair, and thank you so much, Dr. Yara, for going through all of the things as best as you could in the time. Yeah, that was really, really beneficial, and I think everyone can say that they gained a lot from that. I gained a lot from that myself. I was just like making notes as you were speaking. Um, yeah, so some questions that we've received. If anyone has any questions, you are welcome to put them in the chat from now on. And we will be asking Dr. Mohammed these questions. So please put the questions in the chat. Um, Send this to your friends so that your friends can also put it in the chat as well. So yeah, one question that we have received is one question we have received is what causes a delayed menstrual cycle?
So I saw that question and I didn't really understand what they meant by that question. So is it a delay right at the beginning or is it a delay halfway through the cycle? And I couldn't really answer it because I didn't know where it was where they're going with it.
So I think what we can say from that question is,
Ask us that better or
sorry, who's speaking? Oh, I think we could say some people have delayed, like their periods are maybe irregular,
Okay.
or it can be delayed every month by different days, because I know that happens.
So uh, there's a lot of factors that goes into our menstruation. Some women might just have a naturally longer cycle, and that's normal for them. Some women might have a period that's not regular, that's linked to the way they release their hormones. And if I can just try to see if I can go back to my first slide, that always helps me explain to patients. Just bear with me now. I'm going to show my IT skills. Can you see the presentation again? Yeah, okay. So just go back to doing it in a silly way. Just 1 minute. So if you go back to this slide, oh, 1 second, it's now doing the silly thing that it does to end the presentation.
We can still see the slide, Doctor.
You can hold on. If I end the show, then it won't. Just want to show you because it helps. It sometimes helps explain, but it just when it does it as a presentation, it slides up through. Yeah, okay. So if you look at this bit of the slide and our menstruation, it does depend. So it does depend on where we release our hormones and what hormones we're releasing at what stage of the cycle. And so the first hormone that comes through is the estrogen, and that will build all of this up. And if you can see with my pointer, so this is you start menstruating, you release all of the estrogen up until you produce the egg, and then you get another hormone called the progesterone, which either keeps the same because you've fallen pregnant, or comes down, and there's where you have your period. Now that cycle, sometimes in some women, will the release of their hormones will change, either because that's normal for them, so they're not releasing the right hormones. Sometimes it's linked to things like polycystic ovaries or linked to how they get that surge of the hormone, how their hormone releases itself. And that's sometimes linked to their own metabolism of that hormone. And so instead of the hormone, and this is what happens with polycystic ovaries, for example, instead of your hormone releasing at the same stage and kind of peaking up mid-cycle when you ovulate, you don't get that peak. And that's maybe because the breakdown is related to your own diet or your own, if you're overweight or if you've got a lot of stress, and that sometimes causes people not to have their right cycle all the time. So and I think another question was what's the hormone imbalance? But that kind of surge in the cycle and how your periods are sometimes related to which hormone you're releasing in which part of your cycle, and whether you get enough estrogen related in the beginning of this cycle to tell you other bits of your body to release an egg. And if you don't have that because you're pre-diabetic, for example, or you don't have a healthy lifestyle, then sometimes that doesn't happen, doesn't ovulate. For some women, it's just normal for them. It's just the way their body is metabolizing that hormones, that they don't produce the right hormone, and so your cycle is not exactly on that irregularity. And sometimes they'll have a cycle that comes every month, 2 months. And sometimes it's normal right at the beginning of your adolescence. So you're getting your period, and your body still doesn't know which hormone to release, and then you're stopping your periods, and again your hormones are changing again, and that might affect it. So there's a lot of things that might cause your menstrual cycle not to be accurate all the time. If it's just a hormone with no other body problem, then things like reducing your carb intake, being healthy, reducing your BMI sometimes just helps with that. And sometimes other things in life which we forget about, stress, unhappiness, depression, sometimes will change the way your hormones are released, and so your periods might be prolonged or absent in some women. Does that answer the question?
Yeah, thank you very much. That was really interesting. And also I liked what you said about how there's so many other factors in your life that can affect periods, such as, stress that we often overlook, I feel, as women, and diet as well, and exercise. Um, I think we can overlook how big of a difference that can make to our cycle. So I think that's a really important point to make.
Absolutely, absolutely. I think I always tell people you just need to sometimes look at the other bits of your life,
Mm. Yeah, more like holistic view.
holistic view.
Yeah, as opposed to just like specifically there's one reason as to why you're getting this pain. There might be so many other things. So yeah. Another question that we've got is um, how many weeks after a surgical miscarriage do you get a period, and when is it time to get worried?
So it depends. Your hormones from a pregnancy, whether you have had a pregnancy loss or termination or medical management or surgery, sometimes will stay in your system for about 6 weeks. So for some women, even after you've had the loss, you will have 6 weeks before your periods start to regulate again, and that's normal. Um, but sometimes if they advise women after they have a procedure to do a pregnancy test 3 weeks after, just to make sure that you don't have it, because by then your hormone level should have come down, because again that will stop your build up from the ovulation. So it depends on each woman to another. Usually by 6 weeks to 3 months, you should be getting a period again. And if you don't, then you should go seek medical help.
Okay, so around after 3 months' time is where
Yeah,
you would be worried.
expect it for 6 weeks. So if you've had a miscarriage, 3 weeks after you've had a procedure, do a pregnancy test to make sure that that's negative. And if it's not, then you need to go to the emergency gynae unit. If you are negative, then you should have, after your procedure, about 6 weeks start to get periods, but up to 3 months is normal for some women.
Okay, thank you very much. I hope that answers the questioner's question. Also, if you do not want to put your question in the chat to everyone, you're welcome to send it directly to myself. If anyone would feel more comfortable with that, then I can share it with Dr. Mohammed. Um, I've got another question similar to um, previously when we were speaking about PCOS. So I've got a question that says, is early marriage beneficial to ladies with PCOS?
PCOS isn't a contraindication to marriage. So I think any gynecological condition isn't a label to not being able to get married and start a family. And I think we get that a lot within our communities. I feel
Yeah,
really strongly about it. So it's not a contraindication. There's so many factors within fertility. My interest isn't fertility, so I've not gone in, but there's so many factors into fertility. Polycystic ovaries is very common within our ethnic group because diabetes is very common within our ethnic group. What polycystic ovaries is essentially, in a nutshell, is that you might not ovulate. So that day 15 ovulation might not occur all the time. And that's because you start with building up on estrogen, but halfway through the pathway of releasing that right amount to tell your brain to secrete the second hormone, that doesn't happen. And so it builds up a bit like a traffic jam, and it starts producing other hormones, which are testosterone, because that's a byproduct from it. That's why some women with polycystic ovaries will complain of abnormal hair, will complain of things like that. But essentially, that condition is related in some women, not all women, in some women, to BMI, to body weight, to how you metabolize your estrogen, how much carbs you have, and actually controlling that might help regulate your period. And a lot of the work that's been done is reducing your body weight by about 10% might help regulate the hormone. Now, there is a group of women who will have polycystic ovaries and have a normal BMI or have an under BMI. And there's so much treatments that you could offer to help regulate their period, to help them with fertility. So it's not a lot of women link, well, I've got this, it means I won't have a baby. I've got this, it means it doesn't mean that. There's treatments that you could offer to help. For some majority of women, they might not need treatment. So polycystic ovaries, a lot of women fall pregnant with no problems. Endometriosis, some women will fall pregnant with no problem. But as usual, there's a subset of women that will need help, or couples that will need help because it might be male factor as well. And unfortunately, there's always going to be a group of people that won't get pregnant. And I think don't label yourself and say, well, this is definitely not going to work for me, because you never know. So yes, go ahead and get married.
I think that's really important to say. As the person said, people with PCOS are usually advised to marry early. And as the doctor's saying, don't, limit yourself with the label and say, let me just get married just in case, because it affects people in different ways.
So
Um,
I'll tell you how that works, that comment works. So just to elaborate on that. So a lot of people that have, health problems, whether they're gynecological or non-gynecological, are advised to have a pregnancy earlier. And the reason for that is so you're born as an embryo with so many eggs. That's how women are different from men. They don't produce a different, men will always circulate. So they're they can be of any age and they'll still build up their semen, although they might be a different quality. The eggs you're born with are the ones you live with until you reach menopause. And so if you have any condition, any health condition, the advice of getting married and having a family early is because of how much ovary reserve you might have. And so a woman, in her early life will have a bit more than as she gets older, and that's where that comes from. So the advice of, yes, starting a family early isn't just because of this condition, it's because your reserve, and so your chances will get less and less as you get older. And so the advice is you start early. So that just explains that a bit more, because I think it confuses people when someone says that.
yeah, I think that makes sense. But I think it's important to note that some women might feel pressure to then get married earlier and then end up in a marriage that maybe they wouldn't want to be in just because they've been told to get married earlier. I
Yeah.
think, yeah,
And that,
so
and that and that won't help your cycle because then you'll be stressed and you
yes,
won't ovulate.
exactly, exactly. And honestly, everything is in the qadr of Allah. Some people are told that they can never have children and then they end up having children
Yeah.
sometime later.
So
And
none of these conditions equal, none of your health conditions equal definite, oh, you won't get pregnant. Just sometimes you do need support. And there's only a small group of people that people say to them, actually, it's unhealthy to get pregnant because you've got this medical condition. But that's not all of us. That's only a small group of women.
thank you very much. Um, I've got another question saying, um, Jazakallah for this very useful talk. Is it normal to vomit whilst on your period due to a lot of pain?
So that's not normal. Always remember that your periods, so your period, a normal period, uh, either from flow or pain, should maybe make you a bit uncomfortable. Maybe you feel a little bit not right. But if you're having an extreme that it's stopping you from doing activities from daily living, then it needs something doing. Whether that's vomiting, whether that's extreme pain, whether that's flooding, all of that is not normal for a period. Some women, if they get a lot of pain, it might be a time for them to start seeking medical help because it might be that they have endometriosis, or some women will have it linked to like severe premenstrual tension, and so sometimes that's the time to seek medical help. It might be that you just start on the pill and see how you get better. You might not always need surgery or need something like that, but definitely if it's limiting you, that you're affecting your activities of daily living, or some women will say, I don't go to work, or I have to think about changing my trousers. And we all have to make considerations when you're on a period, but if it's changing the way you have to do things because you're on a period, that's when you need to see medical help.
Okay. I think just in terms of the like vomiting and throwing up and being in that much pain, it's sometimes difficult to realize that that's not normal. And sometimes some medical professionals will say that it's normal, or like they might not realize it's not normal, or say that it will stop after a couple of years, and then 10 years have gone by and that person is still in that much pain.
And unfortunately, that happens a lot. And that's, and that was what I was quite pleased to do this talk. Um, sometimes people will have some conditions when they're younger, like they vomit or they're in pain. And sometimes people won't accept things like, why doesn't this young girl just try the pill for a few months? Because that will help her. Because at that stage in your life, you might just need something to take the edge away. But if you are still suffering or still continuing to suffer, then sometimes you need investigations. It might be that you come back with saying, actually, there's nothing we can do, there's only this we can do, but at least you've been investigated to make sure it's nothing like, like endometriosis or something else. And so sometimes it is just treating the symptoms, so treating the problem, the problems it's causing you. Sometimes you don't need the treatment of the condition the whole way through, because sometimes the condition can be just managed without needing it to be taken out. And vomiting is one of those. Sometimes it is something people might, as they get older, get better from, but you still need something to support you with it. You can't have a period, especially for the younger girls in school or in college or university. You have to have something that helps you manage that symptom.
So what would you suggest for someone that is, at that stage where they're vomiting, they've been told it's normal, maybe by their GP?
I would try I would try the pill. I would try the combined contraceptive pill. There's a big fear from the combined contraceptive pill. A lot of women, are scared of putting hormones in them, but it's reversible. And so sometimes it might just help control that hormone level that you get each cycle. Sometimes with the combined pill, you can take it for 3 months without a break to see how you get on, and then you cycle it through and see if that helps your symptoms. So although it might not treat the cause of the problem, it might help control the symptom until you're ready to stop the pill or ready to start a family, and then it might get better, or it might need investigations then.
So, are there any side effects of taking the combined pill for prolonged periods of time?
So the main thing with the pill is that it's estrogen and progesterone. So because you're taking hormones, taking it for a very long time may slightly increase the chances of having a blood clot or breast cancer if you're taking it for a very long time. But that's actually on a background risk very, very rare. And so it doesn't cause any long-term effects to fertility, which is, I think, what a lot of people are worried about. It's completely reversible when you stop it. And so even if you're taking it for a few years, then it's absolutely fine. Some of the fears that sometimes come from women, regardless of their backgrounds, actually, is they go on the pill quite young, and then 10, 20 years, or they get to 20 years and they say, oh, we want to start a family, we want to come off it. And then their symptoms come back. And so in their heads, they think, oh, this must be a side effect of the pill. But it might be that the pill has really controlled your symptoms, and now your symptoms have come back again. And so it's not all related. Or if you had a problem initially that the pill controlled or masked, and then that problem shows up again in a few years, it might not be because of the pill, it might be that the problem was always there. Um, I personally find it very useful in women and young women, that are not planning to have a family soon, just to help control their symptoms rather than go down the route of having a lot of operations and a lot of surgeries at such a young age.
That's really helpful. Thank you. And I hope that helps the person that asked that question as well. Another question that I've got is a 19 to 21 day cycle normal?
For some women, yes. As long as it's regular for some women, yes.
Okay, so would you say it's more about what's regular for yourself
Yeah.
as opposed to
And that's why keeping the diary is important, because
mm,
sometimes someone will come and say, oh, my period is completely irregular, and actually the period is regular. It's just a 35-week cycle, a 35-day cycle. It's still abnormal, it's still prolonged, but it's not something that's abnormal or always due to a problem. It might just be normal for you, or it might be just short for you. It might just be a normal thing for you, a variant of the norm.
so then if, for example, if it was 28 before and then now it's changed to 21, would you then say that then that should be something to think about, investigate?
No, not necessarily. It just might be your ovulation's a different day. So your period will be at some stage, and your ovulation's not always halfway through the cycle. It just depends on when you secrete that hormone. And if your period is still regular, that's normal.
Okay, thank you. Um, so I've got another question. Someone has said, I've been told that I have a low ovarian reserve and I'm worried that I will not conceive.
So again, like I said, I don't do fertility. The low ovarian reserve is linked to what we were saying before. So you're born with a number of eggs, and your low ovarian reserve looks at the hormone that's left in that egg. So how much is left over? The way the hormones communicate with each other in our body is they send the brain something called a negative feedback. So when we have too little, it sends a different hormone. Having a low ovarian reserve might mean that you need support conceiving. And so it might be something that if you're trying for a pregnancy, you seek medical help and fertility help quickly, because it has implications. It doesn't have implications for your overall health, but it has implications for your fertility. So I'd definitely say if you're being told that, it might be that you need support for fertility.
Okay, thank you. So they might have to go down, getting some, maybe doing tests and things like that.
Yeah, so it'd be something if once they start planning for a pregnancy, they might be, they might need to be referred for like reproductive medicine to see whether there's anything they can do to stimulate. And again, it depends on the level of the reserve and how high, how much they've got, whether it's something that they need, they'll be able to get pregnant on their own eggs or whether they need support. Doesn't always mean that you won't get pregnant naturally. It just means that the reserve of those eggs that's left over aren't as good as they were. And so you need support with that sooner than someone who's trying for a pregnancy naturally.
Okay, thank you. Another question that we received was, how long can you take the combined pill without taking a break to manage heavy bleeding and pain? And would the progesterone only pill be a better option? So it's two questions.
Yeah, so you can take the pill as long as you need it to manage pain. So there's no time limit for it per se. The progesterone, so the progesterone depends again, you can have it as well you can have it instead of the combined pill. You can have the progesterone coil, the Mirena coil, instead of the combined pill. They work, the only thing they do, the progesterone, is it stops the period, not temporarily, not permanently, just temporarily, sorry. If the pill is working well for you, then by all means stay on that. If not, and you feel that it's not controlling the pain, then you can go with the progesterone. But there's no time limit to how long you can stay on the estrogen. The only thing that as you get older, if you're smoking, if your BMI is over 35, the risks of having clots with the combined pill increases, and so you might be advised to go on a different contraception. But if it works for you, don't stop it unless it becomes something that you're advised to try something else.
What would be the, I guess, difference in terms of the combined pill and progesterone only pill?
So
And
the combined pill kind of mimics the cycle a little bit. So you get estrogen and progesterone, you get both hormones, and then you'll have a withdrawal bleed in the end of it. So you always have a period, but it's still, you're not ovulating. It's not your own kind of release. The progesterone works on a hormone that works on the end of that cycle, that other bit. So it causes the lining of the womb to be thin and it causes that to be continuous, so it stays the same. That one you have to take it all the time. You don't have a break from it because it works through a different mechanism. There's other forms of it, and actually what we tend to use a lot more is the hormone-based coil, because that will sit in the womb and work locally and not give you that much absorption of the side effects of the progesterone. The side effects for progesterone mainly is the bleeding that may be irregular. So some women don't like that because it disturbs their prayers. Some women might get a bit of sore breasts with them. So it's just a different pill. When you're a smoker or have a history of a blood clot in the legs or the lungs, or as you get older, you are advised to do the progesterone only, just because it reduces your own chance of having a blood clot. So just the benefit of the different medication, really. Does that answer that question?
yeah, yes, it does answer the question. So would you say that if you're younger, it's better to use the combined pill, or does it just depend?
It does depend. So if you're younger and you want something that you still have a period with, and the combined pill is working well for you, then go with the combined pill. If you're older, so usually you're over the age of 35, and you're going to keep up with taking the progesterone only pill, then the progesterone only pill or the implant or the coil work much better for that age group. In saying that, some women, even the younger women, would benefit from the implant or the implanon or the coil or the pill. But with the progesterone only pill, you need to take it at the same time. And so it's about maintaining that. The combined pill, you still need to take it in the same time, but you've got a bit more of a window.
Okay, thank you. Um, So got another question. Is it okay to refuse medication for HTR to slow down menopause?
HRT, like human replacement.
Yeah, I think
Yeah,
so.
so it depends. So HRT depends. So HRT depends on what symptoms you're getting. And it's usually so it's usually when your menopause starts. If you have, if so, essentially what happens is the ovary switches off in menopause, and so you're not producing hormones anymore. Some women will get symptoms like hot sweats, feeling unwell, very irritable, and so benefit from having that replacement. If you have menopause earlier on, so if you have it under the age of 50, then actually having HRT or having even the combined pill helps with giving you the hormone to maintain your other benefits of health. So your bone health, your heart health, your motor your your memory, things like that. If you get to an age of 50 and your periods have been fine otherwise, and you don't want HRT, that's absolutely fine. Because it's only replacing the hormone that you've lost. Uh, you would have lost anyway, so it's just helping with the symptoms. But you might still have the symptoms of menopause. You might still need support from that point of view. And so, leading a healthy diet, making sure you get the right vitamin D, making sure you do kind of weight-based exercise helps with your bone health. And that's the importance, is it's the bones. Because as we're living longer and we're reaching menopause, like say 50, 52, 53, and then you're living till 70 or 80, your bone isn't as strong it is, and now it's got 30 years. And so if you have a fall, you're more likely to break it. And that's where HRT is useful. But if you're fine with the symptoms, then you don't need it. It's absolutely fine.
Okay, thank you. I hope that answers the question. In terms of endometriosis and getting a diagnosis from it, you said something about you need to have the laparoscopy to diagnose it. So that makes it difficult for women to know if they have it or not without that. Um, is there like another way to find out, or is that the only way?
So with endometriosis, it's the symptoms that it causes that people are kind of, you get a suspicion whether you have it or not. Sometimes when women are examined, you can see whether they've got severe endometriosis. The scan doesn't always show it because it's implanting inside the other areas of your body. And so the laparoscopy is kind of the main way to be able to get that diagnosis, because it looks inside. It's an operation. So you come in, you're asleep. It's keyhole surgery through the belly button, and we have a look at inside what it is, and then see whether you've got signs of endometriosis or no signs of endometriosis. And the laparoscopy, if it's minor or sometimes major, helps us take it out. There's no other kind of that you can diagnose it by exclusion. So, for example, if you go in on the pill and your pain gets better, it might be endometriosis that's got better. And that's why I was saying in the beginning, for younger women that have problems with their periods and pain, sometimes going on the pill for a bit avoids them having a lot of laparoscopies at such a young age, because it might help their symptoms, and essentially that's all you need to do. Um, in women that have things that suggest that they have endometriosis affecting the bowel or the bladder, an MRI is useful to identify if there's anything infiltrating into it, but it doesn't give you that full diagnosis. It just gives you whether there's endometriosis that might be deep enough to affect other organs. So essentially, the laparoscopy is your gold standard for treatment, or in a diagnosis of exclusion.
So if you use the pill and it got better and you suspected you had it before, would then the GP say that then you had it or you have it, or would they suggest that
So
you
if you have, so you sometimes you might get pain from endometriosis, or you might just get pain that's not related to endometriosis, and it comes in stages. People are sometimes fixated that if you take it out, it'll never come back, but it does come back and it comes in stages. So some women might have it mild, some people might have it severe. If you go on the pill and it helps your symptoms, your GP might say you've got symptoms that are suggestive of endometriosis. So you're possibly got endometriosis, but it could possibly be other causes. But if a lot of these conditions, if we can support them or we can treat them without needing surgery, then having them isn't a problem. It's one of those things that you might just have. And as long as we help control the symptoms, and if the pill is doing that, that's absolutely fine. Some women are worried that there's a delay in diagnosis, and so it might get worse. And again, that would depend on the symptoms. And so some women might not get a lot of symptoms and have really bad disease, and some women might have a little disease but a lot of symptoms. And so if your symptoms are not resolving or not getting better with the GP, then actually you do need further investigations, regardless of the label that's given to you by the GP. Does that answer a bit of your question, I'm sure?
Yes, it does. When you say further investigation, do you mean being referred for a gynae?
Yeah. So being referred. So if you go on the pill and it helps you, then it's fine. You don't always need a referral up until you're trying for pregnancy and maybe you're having problems or your pain reoccurs. But if you are still getting a lot of symptoms and you're still uncomfortable and you've tried the painkillers, you've tried the pill and it's not helped you, then you do need a referral to gynae. You do need further investigations.
Okay. And if how would you be able to get a referral to gynae?
So through the GP, if you're, say that this is what you're worried about and you've tried this and you're still in pain, then your GP will refer you through.
Okay. So would you say you need to try the pill before you get referred? Or could you just be referred if you
So
have?
again, it depends on your symptoms. If you have symptoms that you're not managing, then I would say try the pill and see. Because sometimes that's what your gynecologist will advise you as first line. If you find that actually you don't want the pill or you're really concerned about it, then you can get referred. But the pill is a valid treatment and the pill will be offered to you by the gynecologist as well. Sometimes you won't get offered the pill. Sometimes they'll offer you the Mirena coil or a progesterone only contraception because that also is treatment to hormonally control these conditions.
Okay. And are there any, if someone, for example, because I know a lot of women don't want to go down the pill or hormonal treatment, are there any treatments that are non-hormonal, or
Killers.
anything?
Yeah, painkillers. So if you don't want hormonal treatment because you're trying pregnancy or you don't want to have the pill or you don't want to take it, then you just have to take painkillers. Or then if you get referred, you might need surgery to remove endometriosis or to do the laparoscopy. But then with a lot of these conditions, they might come back. Even with the cysts, if you have an ovarian cyst and we take it out, it might come back in the future. But if a lot of women are very wary of hormonal treatment, and so it's always your decision and your kind of preference. But if that happens, then it will be getting referred for surgery or consideration of surgery or pain relief if you want something else.
Thank you. That was really thorough. Um, as I've said before, if anyone has any more questions that they don't feel comfortable sharing in the chat with everyone, you're welcome to send it directly to myself. Um, I have another question, which is about the eggs, I think. So it says, please advise on premature ovarian insufficiency and how to treat it. I know you said that you're more on the period side, but that's just a question that we've been asked.
Yeah, so ovarian insufficiency is sometimes when the ovary. So this is just a basic view. So it's again going back to what we were saying before about not producing the right amount of eggs and having a low ovarian reserve. So it's a different name for the same condition. And again, if you don't have enough eggs, then you might go into menopause early. There's no kind of treatment for that. Unfortunately, it's the way we are made as women. So we are made that we're produced with this It's like if you have a pot of gold and your gold comes less and finishes, it's the same thing. Sometimes the treatment again is symptoms, but there's no unfortunately treatment that can bring back the eggs. It's one of those conditions that HRT or hormone replacement that we discussed might help with the symptoms, but it's the reserves that are not there.
So essentially, it's just how you've been made,
Just
and
the
just
way it's just you've reached your menopause essentially before you should have before 50, and that's because the reserves that are held within the ovary have decreased and they're not enough. So the treatment is really to treat the symptoms, but that cause of the problem isn't reversible.
okay. So something like IVF wouldn't be able to.
So IVF depends on a lot of factors. Sometimes, depending on how much reserve you've got, they'd be able to support you using your own eggs. So if you've got some eggs that they can harvest and take, and again, this is not my field, so I'm just giving a really broad view. Sometimes they offer you to get donor eggs, so have someone else donate their eggs and you get a pregnancy that way. So it would depend on your reserves and how much you've got left over, what they can use for IVF.
Okay, thank you. We have another question which is pregnancy related.
Okay.
It says, what does Dr. Mohammed think of pregnancy of 40 plus, and any advice?
In age, 40
Yes.
plus in age. So 14 over the age of 40, your fertility is reduced. You obviously have a lot more risks associated with the pregnancy. So you've got more likely to get chromosomal problems, you're more likely to have a miscarriage, you're more likely to have other medical problems in the pregnancy, so develop diabetes or high blood pressure. We do offer, if you choose to get pregnant over that age, that we scan you quite frequently just to make sure baby's growing, because the placenta, what feeds the baby, doesn't work as well as when you're younger. We also offer kind of to deliver you at term. So usually if you get pregnant a bit younger, then we could wait 10 days after your due date to make you go into labor naturally. So over the age of 40, your pregnancy is not completely kind of a no-no, but it's a higher risk pregnancy, especially if you've got other medical conditions, because they might get worse in the pregnancy because you're taking age a factor and whatever condition you have. Obviously, our life has changed now, and we do see a lot more women get pregnant over the age of, some women won't get pregnant till over the age of 35, and so there's a lot of support. But as you get older, especially over 40, over 45, your risks of the pregnancy do increase.
Okay, thank you very much. That's really helpful. Um, so I've got a question about periods. Um, it says that, is period pain genetic or hereditary?
There's no evidence that it's genetic. We do get a lot of families that will say, my mom had a hysterectomy so many years ago, and I've got the same problem. And so it might be, but it's not, there's no evidence for it either way. So you don't have a gene that carries, heavy periods or endometriosis. There's no research supporting it. And so the short answer is I don't know for sure, but there's no evidence at the moment to say so.
Yeah, because a lot of people do say that, and we have seen a lot of people that, it starts with their grandma, their mom, and then them. And
Yeah,
then, yeah, I guess some people it just comes to them randomly. So I
yeah.
think it's quite a common thought that it can be hereditary.
It might be, but there's no evidence at the moment. It might be that, years from now, people discover that it might be the
Yeah.
answer. We just don't have the evidence at the moment.
Yeah. Okay. Thank you. Um, so I've got a question that says, can a menopausal woman get pregnant?
So the answer is no, because menopause essentially is the eggs that were produced that you were born with have finished. And so women that are menopausal won't get pregnant. Now, the exception of that is if you have premature ovarian failure or menopause early, then some women might get the odd egg that releases. And so for those women, they might quite rarely get pregnant. But essentially, once you have a diagnosis of menopause, then you're not going to get pregnant because that's the end of that reproductive cycle. That's the end of your reproductive health lifetime.
And how would you get a diagnosis of menopause, or how would you notice if?
So it's your periods stop essentially. Your periods stop, and it's usually women that are older. Your periods stop. They might get hot flushes because of the way their hormones are. Might get a bit moody, get a bit of dryness, especially in the vagina. But usually the periods will stop, and it's once your periods stop for at least a year and a half to 2 years, then that suggests you're menopausal. The tests that we do looks for those hormone levels to check whether, some women, their periods might stop because they're not postmenopausal, they're not menopausal, but their periods stop because of stress or because something else, and their periods will restart. But once you get a diagnosis and it's confirmed by 2 separate blood tests that you're menopausal, then you're menopausal. Especially for women that are younger than 50. Over the age of 50, if your periods stop and you get all the symptoms, then we don't routinely do blood tests to check it.
Okay, thank you. And what other symptoms would you have apart from maybe less period if you're under the age of 50 or even
So
over?
under the age of, so it's the same symptoms regardless of when you get it. The only thing is that at the age of 50, if your periods stop, then we don't need to double check it. Sort of, it's the opposite. So it's sort of like if you start bleeding at the age of 13 or 14, no one's going to check whether your periods have started because that's when we'd expect it to have. If your periods start to stop and you don't get a period for over 6 months after your periods have started, then you do need to be checked to check whether you've got early menopause or whether you've got another cause for your periods to stop. Unless you're obviously pregnant or on the pill, that will stop your period. If you're not taking anything, then and you don't have a period for over 6 months and you're under that age, you need to be screened for menopause.
Okay, thank you. How would you know if, because I know some people that have PCOS, they can have a period once or twice a year. Um, how would you know the difference then with
So
menopause?
for polycystic ovaries, for people who've got polycystic ovaries, the recommend so that if you have that condition, your periods are irregular, then the recommendation is actually that you have a period at least 4 times a year. And that is because the buildup of that lining of the womb needs to be shed. So, because if you've got polycystic ovaries and you don't have a period, then if that lining of the womb is being built up with no right hormone supporting it, then the risks of having an abnormality of the lining of the womb, which may lead to kind of cancer if you're older, then it's quite high. And so you should actually be taking, and it might not be a true period that you get, but you should be at least getting 4 periods a year. If you are on a progesterone-only contraception as a treatment for your polycystic ovaries, so you've got the Mirena in or you've got progesterone-only pill, then that's okay not to get a period because the lining of the womb it's thinned out with the tablet. But if you're not on anything, you should get at least 4 periods a year. And if you don't, then you should see a GP to get that sorted.
Okay, thank you. Got a question that says, any advice on vaginal dryness?
It depends on vaginal dryness whether it's related to menopause or in what context, to be honest. So some women within menopause will get vaginal dryness, and there's a lot of treatments that you can do within that. So one of them is there's a lot of lubricants that you can get over the counter that are non-hormonal. But you can also get like HRT tablets that your GP can prescribe that will help with that. if you're getting vaginal dryness as part of issues that you might have with kind of being intimate, then that sometimes might be just the way your estrogen is. And so you might need support with that, or you might just need lubricants for when you have a problem. And so it's very difficult to advise just with that because it depends on the cause really, more than just have vaginal dryness.
Yeah. Well, if the person that asked that question has any more context, could you please directly message me and then I can elaborate on it later. But other than that, I can move on to the next question. So does having a low egg reserve mean that there's low chances of getting pregnant? I think we kind of touched on that before.
Yeah.
Yeah. Yeah, and I think the doctor said that you've got a certain amount of eggs from when you're born, basically, and it decreases every month. So it's just every month. Am I saying this right? That there's
Yeah,
like
so if you have a low egg reserve, it means that what you're born with, so you're born with so many millions of eggs, and if they kind of decrease every month, and if you have a low reserve, it means that you don't have enough eggs there left over, and so that reduces your chances of getting pregnant and increases your chances of going into menopause early because that's the same thing. That's a part of the same function. The cause of it is that your egg reserve have reduced.
um I've got another question that says, does prolapse affect the irregularities in maturation at the age of 40?
The irregularities of maturation. Don't understand what that means. So prolapse. I think they meant menstruation. So not
Oh,
normally, not normally. A prolapse is usually related to, and again, I don't do urogyne, but I'll lapse as much as I can. It's related to your ligaments. So after you have a baby, you've stretched your ligaments supporting the vagina, and so you might get a prolapse because of that. It doesn't relate to your menstrual cycle. It's not hormonal. It is to do with the support mechanisms of the kind of the ligaments of the muscle. What you need to do to help with the prolapse, the first thing and the simple things is your pelvic floor exercises, your weight control and your exercise, generally being able to hook control those muscles, being able to help them to help with the symptoms. And if that doesn't work, you might need surgery for it, but it's not related to your periods. They're two different streams of work.
thank you for that. I've got another question that says, does using a mobile phone affect menstrual pain or menstrual cycle? Is there
No,
any evidence on
no,
that?
no evidence of that.
I know yeah, sorry.
Affects your brain being able to work, but other than that, no, it's not. No, it's not related. It's not related.
Okay, thank you. Because I know a lot of people can say
Yeah,
that
no,
the phone, the radiation or whatever.
it's not related.
Okay, thank you very much. Um, got a question here that says, just in terms of period pain, how would you be able to measure that your period pain is too much compared
It's,
to
it's,
normal?
I think it's personal. Pain is personal. We always forget that. Sometimes we victimize women a little bit because, you say, well, she's got pain threshold, that's this and that. But pain is personal. If you are troubled by it and if it's something that's disturbing you, like I said, some women won't have a lot of disease but have a lot of pain, then it's your own pain, it's your own ownage of that pain. Um, and so it's a personal thing. There's no measure for it. There's no measure on whether this pain is too much. If it's affecting you and it's affecting your own activities of daily living, then it's painful for you. Sometimes within our community say, oh, I've had worse pain than this, and it's not as bad as labor pain. But if it's painful for you and it's affecting your own activities, then it's painful. You don't need validation for that pain.
Thank you for that. I've read that like some people's period pain can be like very low compared to very low labor pain. I don't know if that's true or not.
So it depends, and I mean, it's very difficult to say that because again, even labor pain is different to different women. But some women will get, some women are really, really suffer with their periods where they can't get out of the house because they're in pain, and that's painful. But even if you feel that your pain is affecting you and you're struggling with it, then that's painful for you. You don't need the validation of it being as bad as labor pain or toothache. Sometimes we compare it because we just need to understand. But if it's painful, it's painful.
Yeah, I think it's really important to say that because sometimes some women that maybe don't get pain might not understand, or the pain doesn't affect their daily life, might not understand other women that have very painful periods, and then might compare, and it just doesn't really help anyone.
And I think it's important to say that because how we perceive pain and where we find it painful might be different. So,
Yeah,
some people might, don't care. If they got tummy pain, they're not bothered. But if their finger hurts, then that's a big thing for them. Or if they got a headache, it's a big thing for them. So it doesn't always compare, doesn't always link to your perception.
yeah. So would you say that if you're not able to like leave the house or,
If you feel that your pain is affecting your own activities of living, if you've got to change your life because you're on a period, that you change it significantly. It's not that you have to take a pill or whatever. You're changing it significantly, then that is a problem. And you shouldn't, you see a lot of women that say, I have to work from home on the days when I'm on my period, or I'll be in the office and I'll be soaking through, and that's not normal. Your period shouldn't be that, shouldn't affect you that much. If you say, well, actually, I'm a bit uncomfortable and I've got a bit of sore throat, but actually, overall I'm okay.
yeah,
Then, I mean, if you compare it, if you have a bad cold, for example, if you're a bit snuffly, then you're okay and you're out and about, then you're okay, you're gonna get better. But if you're really sick and you haven't been able to get out of your bed, then you need treatment. You might need to go to the hospital. If you're older, for example, and when COVID happened, some people were okay, but some people got really sick and passed
yeah,
away from it. So it really does depend on how it's affecting you and your other health problems.
yeah. Someone has said that they get lower back pain on period and not pain on the abdomen. Um, is that is that normal, or what causes that?
Yeah, so for some women they get pain around their back rather than abdominal pain. And again, if they're managing that's their norm for their pain, they're managing with painkillers and they're okay, they don't need anything doing for it. But if it's that severe that it's affecting them, it might be a sign for something else and they'll need maybe to try the pill as first line to see if it gets better or to speak to their GP for a referral. Sometimes some women will get a bit of sore in the back, but it's because they have a problem with the back and they need to exercise the back rather than jump in to think, well, it's definitely related to the period. Because of the change of how you release the hormones, sometimes the ligaments might soften. And so a backache that is probably there, but you haven't really thought about might get worse because you're on the period.
So the person has just said in response to what you just said, um, they asked, would retroverted be the cause for lower back pain?
So a retrovert. So what retroverted uterus means is if you imagine your kind of your pelvis or your tummy like a round plate, yeah. So the uterus will either point frontwards or backwards, and it's a normal variant of where of you of people, yeah. So it's a normal variant. It's nothing. So the majority of people it will point, um, frontwards called anteverted. For some women, it might point backwards, but it's normal for them. It's where their uterus forms. Sometimes the uterus kind of moves back and forth according to where it is. Sometimes having a retroverted uterus, which means it points backwards, puts a bit more pressure on the back, and that might be why you're getting pain. And some women might, when they're intimate, find it a bit more painful in certain positions because of where the womb is, or if they're doing a smear. There's no kind of quick fix for it. It is just the way that you are at stages. So it's not something that's wrong with you. It's just your own anatomy. It's the variations of our body rather than a problem.
Thank you for that. I've got another question saying, is ablation a better option than the traditional hysterectomy?
An endometrial ablation.
Yes.
So an endometrial ablation is basically burning off the lining of the womb. What it does is it works on, so it works for women who have heavy periods. It may or may not help with pain. It's a minor operation, so it's better from a traditional hysterectomy that it doesn't need a major operation, so it reduces the chances of having the risks of having a major operation. When it works for a woman, it works really well because it stops them from having a period. Sometimes you might still get pain when you're due to have a period because you're still ovulating, you're still producing the egg, you're just not getting the flow. The main thing with ablations is in some women, it causes scarring inside the womb. And so in the future, if they needed any procedures, it might become a bit more difficult as they get older. But it's not something that's major. It's just one of those things you need to be aware of. With ablations, you need to be sure that you've completed your family. And I assume if you're discussing a hysterectomy, you have. Because your eggs are still producing, but then you don't have the inside of the womb where the pregnancy implants. So you need to be on some sort of contraception, long-term contraception, or avoid getting pregnant because of the dangers it is. So ablations are safe. They're quick procedures. They're office procedures, and they might avoid you having a major operation, such as a hysterectomy.
Okay, thank you. Would the ablation then affect, it says, the rectal cell and cytocell of first degree?
See the question.
They've sent it directly to me, so it just says,
So
would
would it affect a rectocele?
yeah, rectal seal and cytocell.
Yeah, no. So that's prolapse. So it won't relate to it. So it depends if you're trying to choose what treatment you have. It depends kind of what treatment you've been offered from a prolapse point of view. The ablation will only work for the periods. The prolapse either can be managed conservatively or might need surgery. It's two different things. It won't affect it.
Okay. I think they were asking for heavy bleeds, not for pain.
Yeah.
So the heavy bleeding that's causing chronic anemia.
Yeah, the heavy bleed and ablation will work. If they're suitable to have an ablation, the ablation will work for them. The prolapse will need a different treatment. And so they might need surgery for that or exercises for that, but the ablation will help with the anemia.
Okay, thank you. Because I know as well, heavy bleeding causing, chronic anemia, is also a big problem. What would you suggest for that?
So it depends on the cause of heavy periods, and that's really kind of a lecture on its own. So if you have no cause for your heavy period, so they've investigated and there's no other cause, or you've got a fibroid that's small, then an ablation is absolutely fine. And that will help kind of reduce your bleeding so that you're not anemic. If you have a cause of it, and usually fibroids are a cause of anemia, a cause of heavy periods, then you might need treatment for the fibroids. And again, it depends on where the fibroid is. If you wanted a treatment that doesn't require you to have kind of a lot of intervention, then the Mirena coil is really good. And a lot of people advise it, or a progesterone only pill, because it reduces the amount of bleeding. Sometimes having some women can have injections to give them early menopause, but that's not really for long-term use, but it might help reduce the bleeding to build up from an anemia point of view. Does that answer some of that question? You know, it's a lot to discuss with heavy periods.
Yeah, yeah, because I get what you mean about it being a different topic.
So some of it is linked to each other, but there's a lot of other causes for it.
Okay, so there could be other issues that you have anemia not related to your period, you mean?
So if your period is heavy, so you might have other causes that cause you to be anemic because the way you build your blood is how much iron you have. So you might have a problem that makes you anemic all the time.
Mm.
If you know that your period is heavy and you're causing you to have a low iron because of it, then you've got options to treat that. And that might be, again, things that are hormonal or having an ablation or having surgery to take away the womb or to take out the fibroids or to take whatever you have. So it's different options depending on what's causing you to be heavy.
Okay. And if it wasn't, oh, sorry, go on.
So yeah, and again, like I say, it always depends on where you are in your life, to
Yeah.
what treatment you have, how healthy you are, what other medical problems you will have. And so sometimes, you know, we compare and contrast, or this one said this and that one said that, but it does depend on a lot of factors, to what treatment is suitable for you. So if you've not completed your family, for example, you can't have an ablation, you can't have a hysterectomy. You have to go with the hormones to help you, or non-hormone to slow down the bleeding if you're trying for a family. So again, it does depend on where you are in your life, to what treatments you have, and what other medical problems you've got as well.
Yeah, I think that's really an important point to make because people can like find out this worked for someone else, but that person is about to go through menopause, or this person is, about to start their family, or 14 years old. Do you know
Yeah.
what I mean? Yeah.
So always, speaking to people is good, but sometimes you might not know what their other health problems are that impacts the decision to what treatment they have.
Yeah, so I think the best thing then would be to just discuss with a GP, and if after trying those things it doesn't work, then to ask for gynecology.
Yeah, so number one, discuss with the GP. Number two, there's a lot of really good information available online that is not um, fake news coming from Google and WhatsApp. There's a lot of really good sources, and I put some of them on the slide, like the endometriosis, the NHS website. There's a
Yeah,
lot of effort that's gone into that. So use that to guide. You know, we sometimes don't read enough about our conditions, or we read the wrong websites and build our own ideas,
yeah,
and then speak to a medical profession. Knowledge about your own health is very important. You know, knowledge about what comes, and there's so much information that is good information. So rely on those websites rather than a lot of websites that will feed a lot of frenzy that is not required. So yes, by all means, that I think, well, first line, have a look, have a read, speak to your GP, and then ask for a referral if you still need support.
yeah. I think advocating for yourself is really important. Um, what you've just said about reading up on things that, isn't fake news, reputable websites, and then being able to take that information to your GP, as opposed to some people notice a difference and then it'll maybe take them a year to then go to the GP. Maybe they feel nervous about advocating for themselves, or they
Yeah,
don't have the information.
but I think a lot of people get put off sometimes because there's a long waiting list, but you still get seen if you have a problem, and the GPs can always initiate a lot of treatment as first line in the community before you need further treatment. And like I said, we fear sometimes, a lot of people, they just put me in paracetamol, and I say, well, paracetamol is a treatment for that. But so yeah, sometimes it is actually the treatment that you need, and you don't need anything else. And so trying it, there's no problem with it. trying the pill is no problem with it, because that's maybe what you need. You don't need anything else. Not everything needs a diagnosis and surgery and removal. Not everything needs that. Some do, but not everything needs that. Sometimes just helping the symptoms is enough.
Thank you for that. I think that's a really important point to make, particularly in our community where we can be kind of scared or nervous about going down the treatment route. So yeah, the person that spoke about the ablation said that mentioned adenomyosis, which I know is a different thing that we've not mentioned. And they said perhaps a Zoom session on heavy bleeds might be good in the future.
Yeah, so adenomyosis is endometriosis in the muscle of the womb, and that's a pain. It sometimes causes pain, which gets worse with the period. The ablation might not help with that. The ablation will help with the heaviness of the period, but it's a simpler treatment, and it might be that she might still need a hysterectomy in the future. But sometimes it's a better stop than to go for a major operation. But just an upshot with the ablations, and that's what I tell my patients, that the ablation works really well for heavy periods, but it may or may not help with adenomyosis and painful periods. It might do, but it might not.
Okay, thank you. And the last question that I've got, kind of a follow on from that is hormone testing a good idea for heavy bleeds, and what would it show?
So hormone testing, I'm assuming to check whether you're menopausal or not, whether you've got right ovarian reserves. So for heavy periods alone, it doesn't add that much, to be honest. It adds more for irregularity of the period, or if your periods are stopping, or if you have other symptoms that are suggestive for menopause. Heavy periods usually need another set of investigations. They don't just need hormonal treatments because it's a completely different pathway. And again, like what I said, it's all in the story of your condition, what makes it worse, what's associated with it, which is important to see what investigations you need.
Thank you so much for that. I think we can all agree that this has been a really, really beneficial lecture from Dr. Mohammed. I've learned a lot from it, and as we've received so many questions, I think everyone has learned a lot from it as well, mashallah. You're very knowledgeable, and you've been able to answer the questions in a really well-rounded way, which has been really helpful as well. So Jazakallah khairan for that.
And I'm glad you guys have found it useful. It's really a pleasure to be here, actually.
Oh, thank you so much. It's been very, very useful. And to get a different perspective as well on sometimes we have perspectives of, don't use this, don't use that. And to get from, a reputable source that it's okay to try, and then to go back to the drawing board if it's not working. So yeah, if we haven't gotten to your question, please put it into the Google form that we sent out previously, and we can answer it another time, inshallah. Thank you. Oh, someone's asked about the website recommended. I think Dr. Mohammed spoke about endometriosis
The
forum.
Endometriosis UK website for endometriosis, there is a really good resource in the NHS website for fibroids. And I tend to use it for my patients, actually, direct them there.
Yeah,
And we also have so the Royal College of Obstetricians and Gynecologists. If you type RCOG, there's a lot of patient information there. That's really good. It goes through endometriosis, it goes through PMS, and it's written quite well. It is mainly written in English, but there are resources that are translated.
brilliant. Thank you so much. So NHS website and endometriosis UK.
And the RCOG, our own website.
Yeah, brilliant. Thank you. So yeah, we're coming to the end of the lecture now. Dr. Mohammed, is there anything else that you'd want to add?
No,
Thank you so much, Jazakallah khairan. If we can all, give a big thanks to Dr. Mohammed for joining us today and walking us through something that affects, all of us. And my name is Aisha Adeyemi, and it's been a pleasure to moderate today's lecture. So I'm going to pass it on to Amira to close this.
Yeah. Assalamu alaikum, everyone. Thank you so much, Dr. Yara Mohammed. It has really been an insightful session for us today. And, we say a big thank you, Jazakallah Khairan, for educating us and for spending this quality time with us. I think it's a rare opportunity, actually, because, how, the waiting list, NHS to be able to see a consultant, but you've volunteered to spend this quality time with us. And I pray that may Allah accept it from you as a big, reward on the day of judgment. And I'd like to see this opportunity as well to thank Dr. Lamia for facilitating this connection because, without her, I would not have met you. So thank you very much. And we hope we can call you back again to talk about other, issues affecting women. I am pretty sure that everybody on this call will agree that they are being, educated and going away with, a lot of useful information. Jazakumullahu khairan, everybody for joining. And I hope you can leave feedback for us and let us know what other topics you would like us to deal with in the nearest future. Thank you as well, Aisha, for moderating. And I say, Jazakumullahu khairan. Assalamu alaikum.
Everyone, thank you so much for having me. It's been useful for me as well.
Jazakallah khairan. Thank you so much. Just before we go, we do have our next networking session coming up, which I just want to share just before we go, which is regaining self-esteem and self-confidence. The topic will be a joyful journey of well-being and resilience for women. And this is going to be in person on Saturday, the 10th of February, inshallah. So this will be in a couple of weeks' time from 10:30 a.m. to 4 p.m. And this will be at Longsight Library in Manchester in Longsight. This is a women-only event, and you can register on Eventbrite with early bird discount. Lunch will be provided. It's going to be a really, really amazing session. And we're going to have Zara Mohammed, the Secretary General of Muslim Council of Britain, as one of our speakers. Hafiza Amin, a therapeutic counsellor, as our guest speaker, and Kafaya Abdus as our counsellor / guest speaker as well. So we would love to see a lot of you guys there. If you go on to Eventbrite and search this out, then you will be able to buy your tickets. Early bird discount is going soon. So yeah, thank you so much. And we hope to see you there. And thank you so much, Dr. Mohammed, for facilitating and, sharing your knowledge with us. May Allah reward you. And inshallah, we can see you another time.
Inshallah.
Inshallah.
Assalamu alaikum wa rahmatullahi wa barakatuh.
Wa alaikum assalam wa
Salam alaikum.
rahmatullahi.